All right, so some final thoughts on neurobiology and suicide. I want to start off with some criticisms of the research. So far, there's no biological indicators available that would tell us whether someone is going to attempt suicide or not. So we're still stuck in this position where the best options that we have are asking people about suicide. So we can't do a blood test or a lab test that says, oh, this person is at imminent risk of suicide, so we should hold them. Um, we also know that neurobiological research must consider suicidal ideation and suicide capability separately. Now, we've talked about theories that have helped us with this distinction. That Thomas Joyner was really the one who brought this to people's attention to think about suicidal desire and suicidal capability differently. And the neurobiological research really needs to align itself with this idea, because sometimes they lump together people who are suicidal ideators alongside those who are suicide attempters. Now, the question is, if you find anything different, is it because they have high levels of suicide desire? Is it because of the capability for suicide, or what is it? And so any differences between that combination of groups versus someone who has not thought of suicide, yeah, you really don't know what it means. And so it's really important that the neurobiology and the research in this area needs to do a better job to really define the populations and be able to study them separately. And lastly, and this is more philosophical, we ought to be cautious about reductionism. So we don't want to reduce suicide to a biological explanation. It's not just a product of biological factors. Again, like I said before, our experiences shape our brains. Our experiences change the way our brains work. And so we can never reduce suicide to just, oh, it's just these you know, fewer mature granule neurons in the hippocampus. Well, the question would be, well, why are there fewer? Maybe it's because of genetics, but maybe it's also because of environmental experiences that person may have had of neglect or abuse or household dysfunction, and maybe both, right? We don't have to have a dichotomy. Maybe both are at play. And so again, that I just want to emphasize means that our environment still is very important. And it's also important to recognize that you can change, because of this, you can recognize that we could change the brain by changing the environment. We know that counseling and therapy helps to change the way our brain works, and that's part of the way it helps people feel better. And so it's a bad thing to just say, oh, if it's neurobiological, we should give medications or neurobiological interventions. If it's psychological, we should just give psychological interventions. No, you can give neurobiological interventions like medications, and it will help with the psychological. And you can give psychological interventions, and it can help with the neurobiology, because they're all one and the same. It's right. It's the whole working of our brain and our mind. And so if we eliminate abuse, decrease bullying, if we promote positive coping, if we improve emotional regulation, all those things can help with the neurobiology. And you can avoid reductionism by noting the role of stress and adverse childhood experiences on brain development. And I think that's why I really like this article by Van Heeringen and Mann, is because they did that. They considered how experiences can change biology. And so it's more of a holistic understanding. All right. With those criticisms, I really want to emphasize that there's also a lot of contributions of neurobiological research. There's actually been treatment contributions. There's existing medications that can effectively target suicidality. So ketamine is a general medication. It's also a hallucinogen, so it's called a psychedelic. It's actually been approved for the treatment of depression recently, and what they have found is that it has a anti-suicide effect for about a week after administration. So that's one that leads to change. Serotonergic drugs, right? We mentioned the serotonin system is very important to suicidality. The serotonergic drugs are likely to reduce suicidality. And one thought is that they might actually lead to increased neurogenesis. So the serotonergic drugs include antidepressants, SSRIs. Now, as a side note, antidepressants have been associated with increased suicidal risk in youth. However, and maybe you've heard that idea, however, the article points out that this may actually be false. This may have been done because the thoughts of suicide was not effectively monitored in the control condition when they were doing these drug studies. And so this idea that antidepressants increase suicidal risk might actually be false. I don't know a bunch about that, but I just wanted to point out that the article did talk about that. Some other medications that may help, lithium seems to reduce suicide risk. That's a medication for bipolar disorder. And they say, well, it's not just due to its mood stabilizing effects, because even if a person's mood isn't completely stable, a person's suicide risk is still lower. And clozapine, it's a medication for a number of conditions, including schizophrenia. Also is found to reduce suicide risk, and it's not just due to its antipsychotic effects. So there's been a number of contributions from this research. And existing research could also help in developing new medications, perhaps even targeted medications that could directly address suicidal ideation or suicidal capability. But those medications haven't been developed yet, and so hopefully we want the toolkit that we can use to be as full as possible. So hopefully we can find better medications or neurobiological interventions that can help people at risk of suicide. Okay, well, that's the videos for this section. Hope you enjoyed it.